Thank you. So the next presentation will be
what to do, in persistent
veins are isolated.
Well, it's really close to the previous presentation, but I like just the same disclosures. But I like just to point it out. I mean, just how the posterior wall is, really crucial, and why there is a rationale to aim at the isolation of posterior wall. Obviously, for patients with a persistent or long-lasting persistent AF patient. This cartoon comes from a consensus document that we have written in 2017, and it's nice because it shows the complexity of left posterior wall in relation, to the clinical presentation, like the paroxysmal or persistent atrial fibrillation at the right, and also we have pictures concerning what the posterior wall can host, like secondary triggers, fibrosis, or rotors, if you will, the ligament Marshall, and so forth. So I think we have three main reasons why posterior wall can be included in the framework of ablation of persistent atrial fibrillation. Number one, the posterior wall shares the same embryological origin of the pulmonary veins. So these two structures are intertwined, and that can explain why in some patients we have a paroxysmal and also persistent AF episodes. So this is, probably underlying the fact that you might have different and complex circuits in the left posterior wall. Number two, the electrophysiologic characteristics of atriomyocytes within the posterior wall can play a role. And there are, a lot of data from investigational studies showing a higher incidence of delay after depolarization, large late sodium currents in association to a great amount of intracellular calcium in the sarcoplasmic reticulum. So all this, can promote, circuits, can promote a complexity and a higher propensity to have atrial arrhythmias, and at the end of the day, especially can contribute to the pathophysiology of atrial fibrillation. Number three, left posterior wall in patients with persistent atrial fibrillation is an ideal anatomic location for atrial remodeling, as I mentioned before, comprising fibrosis and also mononuclear infiltration. So we have different reasons why the posterior wall is so important. But we need just to add more. And if you look at the data from goat experiments, these are nice data from Alessi's group in recent years, who demonstrate that there is a sort of dissociation, but at the same time a breakthrough between the endo and the epicardial. And there's the same concept that I mentioned in my first presentation, how it's important just to consider also the epicardial layer in the pathophysiology of atrial fibrillation. And this data serve as a basis for a hybrid ablation that I will show you just in a moment. And if you consider the duration of atrial fibrillation, and if you look at the 6-month atrial fibrillation, the complexity of circuit, the complexity of what happened in the left posterior wall is pretty clear if you compare this to the acute atrial fibrillation. So atrial remodeling, is leading to an heterogeneous conduction, and the number of waves is, likely the same at the endo and the epi. All this information have led in the last decade to devise different modalities of approach in terms of the catheteral ablation. There was long story concerning the complex fragmented potential, and also the rotors and the dynamics process of a cardiac fibrillation. All this information has tried just to be included into clinical practice, but unfortunately, didn't go beyond the philosophic, interpretation without any, clear improvement in a clinical outcome. Obviously, what we need to do in patients with a persistent AFib or persistent that come back just because they have failed a previous ablation. We have in our shelf different technologies, going RF, laser, cryo-energy. But obviously, I will focus on very few technology just for the time's sake. I just mentioned the high power short duration. We have listened to a previous presentation, so I don't want you to spend much time, but obviously this is one of the main technologies capable to lead a durable lesion. I don't use the high power short duration right now for posterior wall isolation, and nor I use the diamantic catheter for catheter ablation anymore, but it's a good catheter. It's is related to a decrease in impedance, and it can create a very good deep lesion, and obviously it works on a conductive process as opposed to high power short duration that is based on a resistive lesion, that much more shallow lesion than what is provided from the diamond tip electric catheter. Let me introduce just one concept. This is the hybrid approach. This is a quite huge program that we have in the institution related to patients with a previous failed catheteral ablation, or patient with a very long-lasting, AF, maybe just more than 1 or 2 years, who are suffering from, the persistence of atrial fibrillation. And I introduce this concept because one of the main aim of the hybrid approach is to create isolation of the posterior wall at the epicardial site. The surgeon with the minimal incision in the subxiphoid region can, easily reach the posterior inferior atrial wall, and with this RF application in this a parallel fashion can, as the mapping over here, demonstrate isolation of the posterior wall, except at the most uppermost portion of the posterior wall, just because the pericardial reflection and the surgeon can go beyond that. So that is something that we do in the second step when we do the endocardial ablation, just to complete, as shown in this slide, the isolation of the pulmonary veins, as shown on the right picture, and the left posterior wall. So this is just a way to promote epi and endocardial isolation of the left posterior wall. We use the H-degree mapping catheter because it's capable to collect a very high number of points. Here we have just an example of a pre-ablation epicardial mapping, just because the surgeon can introduce the mapping catheter at the epicardial site. And we found in this specific case just a a crowd of the fragmental potential, and then when, the surgeon go over there, can isolate the posterior wall. And here you have the example how to introduce at the epicardial space the H-degree catheter in order to map before and after ablation. But I think that we need just to move again to the PFA, because I do really believe that the PFA can make a big change, a big step, forward, even for patient with, recurrences of atrial fibrillation, and they need to have a redo procedure. Again, I like just to emphasize the fact that you have a threshold for electroporation that's quite low for the myocardium as compared to the other structures, and this explains why the PFA is safe and that you can ablate quite a large amount of tissue without having any complications, as opposed to radiofrequency ablation. Here we have just an example of injuries at the MRI after catheter ablation of the posterior wall, or even the cryoballoon, even less frequency can promote esophageal lesion, as opposed to pulse field ablation. And here the graphic, the bar graphic, shows that the thermal injury that you can achieve by radiofrequency in a cryoballoon has much higher rate of esophageal lesions as opposed to PFA. Why this picture? Because anisotropy favors PFA. What does it mean? Well, this is the gross anatomy from a human heart, and it's really nice just to see again the complexity of fiber orientation of the posterior wall that goes into the pulmonary veins. And again, I mentioned at the very beginning of my presentation the same embryological origin of these two structures. And when you apply PFA in these structures, and you have not really a parallel application but perpendicular application, you might obviously get the best lesion size and the depth of the lesion. And it's nice also to remind us that you might reconstruct with a computational process the same fiber orientation and try just to identify the ablation target here at the roof, at the back and bundle, or just in the middle of the posterior wall, the best target to ablate. And again, if you look just at the catheter at the posterior wall, anisotropy makes much larger lesion when a PFA is applied over here than isotropy. And there is one reason why PFA is much more effective than RF if you consider to create a linear lesion at the roof of the left atrium. Look at here. You have an epicardial gap across the roof line when you create the lesion with RF. But the PFA can penetrate layers of fat tissue, and therefore this explains the fact that you might provide a transmurality of the so-called septopulmonary band, which is located here at the roof, and therefore you can penetrate, the most, deeper layer, what, the RF cannot. And this probably is really important if you consider to use a PFA maybe in the future, even the epicardial portion of the myocardium, and just consider even ventricular myocardium. Previous studies have already shown that the lesion durability is very high, not only for PVs but also for the posterior wall, as shown in the manifest PFA registry with quite high rate of isolation. And if you look the outcome, it looks like that even the non-paroxysmal AF subtypes, persistent or long-lasting persistent AF patient can really benefit when you use the PFA on the posterior wall. But obviously, nothing is clear, and we need to admit that data from the Kaplan randomized clinical trial has recently shown that if you add pulmonary vein posterior wall isolation to the pulmonary vein isolation, did not improve the success rate compared to PVI isolation alone. Let me make just a comment. We need to understand what we consider the real isolation of the posterior wall. So if you look what the authors have done here, there's the current modality of applying radio frequency to the posterior wall, your roof line, and you actually, this is a box lesion. But I challenge you, that is not an homogenization of the left posterior wall. And there is another fact. If you consider to isolate the posterior wall in patients with a persistent AF, or just because you need to redo the procedure, once you have shown that pulmonary veins are completely isolated, you need just to go beyond this portion. You need just to go really inferior in the posterior wall, just at the boundary of the coronary sinus, because this is a very crucial areas where you need to ablate. This shows what we have done, and it's my pleasure just to actually, it's under review, but actually just yesterday we received the confirmation of a publication of almost 250 patients treated with the not only PVI but the left posterior wall isolation. And here you have at the bottom of the slide how to move the catheter to isolate the posterior wall, here just represented by the color dots, just to homogenize completely the posterior wall. And this is completely different from the box lesion. So this is something that we need just to understand if we want to reach a result like this here at the right end of this slide, when we have a completed posterior wall isolation, which is comparable to what the surgeon can reach with a hybrid approach. So I think this is the same case that I presented before. So we need just to go beyond, and just before I go to my final remarks, we might think that in the near future, if you consider hybrid ablation, you might use the PFA instead of RF, even for epicardial. And this is a study that has been under review right now, where we compare the Farapulse for persistent AF patient or redo patient to patients undergoing hybrid ablation. Just to be practical, the conclusion that PFA of pulmonary vein and a posterior wall compared with a hybrid convergent ablation, which is EP plus endo, is the PFA is endocardial only, is safer and a faster procedure. The 6-month rhythm outcome at the very short clinical outcome, but still there, was similar in both groups. So I think that and this is one of the reasons why PFA can be the real new avenue for treating patients with the posterior wall. So I think that ablation needs just to be aimed not only at the PVI, and I think that the PFA whatever technology you want to use in the future will be probably your driver to treat patients also with much more advanced, AF as opposed to the much more, simple patient with paroxysmal atrial fibrillation. So I stop here. Thank you.